Good morning, everyone. We'll just make a start again. So welcome to the final session of the conference. I'm delighted to see everyone here and I hope you're all enjoying this so far. And I'd first like to thank the organisers for inviting me to chair this session. My name is Dr. Jolene Moore. I'm an anaesthesiologist based in Aberdeen in the UK. I'm a member of the World Federation of Societies of Anaesthesiologists Education Committee, and I'm programme lead for the Safer Anaesthesia from Education programme. I'm a member of the N4PCC network, and I'm very privileged to be involved in their work and some of the studies that you've heard about in this conference. In this final session, we have 3 excellent speakers lined up, and as before, I'd encourage you to please do add your questions to the chat. So to begin, our first speaker is Dr. Senait Kabedi. Having graduated from Addis Ababa University, trained in paediatrics and completed an MPH at Johns Hopkins, she is Adjunct Associate Professor of Global Health at Emory, Guest Lecturer at George State and Visiting Professor at Ethiopia's St. Paul's Hospital Millennium College. Dr. Senait has over 25 years' experience within the fields of maternal and child health and infectious diseases, working with many well-known organisations, including WHO, UNICEF, CDC, USAID, and many others. Today, she'll be talking to us about the need for improving awareness and research on antimicrobial resistance in Africa's acute care settings. I'll hand over to you, Senait.
Good morning, everyone. My task today is to present on improving the awareness and research on antimicrobial resistance. I will be doing so by going through a few outlines as seen in the slide, starting with the AMR as a global health challenge, development of AMR, and the responses from the global and regional entities, and then end my presentation by highlighting some of the challenges and key messages. Antimicrobial resistance has become one of the leading causes of death based on the recent presentation that came out just 2-3 days ago from Lancet that reported a finding from over 200 countries globally. There was 1.2 million deaths per year due to AMR or directly related to AMR in 2019. And the other finding is that most of these deaths are in the lower and in middle income countries like Asia and Sub-Saharan Africa. In Sub-Saharan Africa alone, over 250 deaths were reported in the same year. Another summary from this finding is that the organisms that are resistant are also the commonly occurring organisms that we usually deal in our clinical practices like E. coli, S. aureus, and the others. Methicillin-resistant Staph aureus alone was responsible for over 100,000 deaths. Not to forget that other pathogens like multi-drug resistant tuberculosis and third-generation cephalosporin-resistant E. coli are also gaining prominence in terms of being resistant. Antimicrobial resistant organisms, be it bacteria, virus, fungi, or parasite, are evolving and no longer respond to antimicrobial agents. That's when we say they are resistant. It is a natural phenomena, but however, this resistance is also accelerated by various risk factors. These risk factors or contributing factors namely include antibiotic misuse or overuse, be it in animals or humans. In addition, the lack or inadequacy of infection control practices, the limitation of diagnostic capabilities, the lack of surveillance and policy and regulations that may not be implemented are also another source that can contribute to antimicrobial resistance. Use of counterfeit antibiotics, which is very common in many developing countries is also another important factor. And then also environmental contamination with pharmaceutical products are also another contributing factor for AMR. Antimicrobial use is not limited to humans, but as we know, it is used in many industries, and the contamination or the use of antibiotics in every product, such as even household chemicals, is also another issue that is contributing. We can see that it's also used in farming. They do contaminate our fruits and vegetables. In aquaculture, especially with artificial lakes and production of seafood for consumption are also another sources, and also the environment. This picture shows the interconnectedness of the resistance transmission between human, animals, the environment, and the health facilities. When we talk about antimicrobial resistance, it is in the health facilities that is very common, though we do get antimicrobial resistance in the community through various routes like consumption of antibiotic-fed animals that are produced for meat production and others. So this tells us that the connection or the intersection between the environment, the animal, and the human health is a very important aspect that is relevant when we are talking about AMR. And also the solution is also based on the One Health approach. So it becomes very critical that we are coordinating, collaborating, and communicating across these sectors if we are to curb the antimicrobial resistance, which is really picking up the pace. By far, the commonest associated factor is the use of antimicrobial. This is a study that is done in 20 industrialized countries that shows with each increasing use of antimicrobials, there is a linear increase in resistance in every country that is studied in the group. The same is true within the animal section. If you see the second graph on the right, in the animal section, the countries that are studied here, there was also a linear relationship between use of antimicrobials and resistance of organisms. We do have studies from Africa, especially the one in 2018 that examined the meta-analysis of 12 country studies, showed that antibiotic resistance in the animal industry was 86% and multi-drug resistant was 73%. And you can see the graph where these organisms were distributed. And this graph shows these factors, and then the low, high, and medium results from antibacterial resistance based on the different factors, the most important factors that are listed. Again, we see that the animal and the human consumption or misuse of antibiotics does feature out as being the most important contributing factor. We do have others like suboptimal diagnostics, suboptimal vaccination, and mass drug administration, and others also contributing as a factor. The development of AMR and clinical outcomes, I think the most important issue is that in the development of AMR, apart from the natural processes, mutation and selection pressures, gene transfer from other bacteria, particularly if we talk about the bacterial side, which may be generated by plasmids and other transduction and transformation processes are very much relevant in terms of studying how the development of antimicrobial resistance occurs. This is one area of research which is which requires expansion and more effort to understand what genes can be identified for the different bacteria in order to target control of antimicrobial resistance. There are so many papers coming out. Some of the processes have a gene that can be shared by a number of bacteria, which makes it amenable to some of the efforts that are ongoing to produce a better antibiotic. The main 4 or 5 mechanisms are shown here. Once the antibiotic enters the bacteria, there are different mechanisms that render resistance and make the antibiotic ineffective for use, like the blocking of the penetration. You see a few examples of drugs that are listed there. Some of them play the role of resistance through target modification in the case of vancomycin and beta-lactams and others. The other one is enzymes, inactivation of these enzymes, particularly in aminoglycosides and macrolides. These features do play a role in making the showing us the mechanisms of resistance. Just to talk about a few examples of resistant microorganisms, vancomycin resistant enterococci is one of the serious organism that we see in hospital infections, particularly in post-operative cases. More than 95% of these infections are caused by the 2 species of enterococci. And this is one of the difficulties that we see in some hospitals. Carbamazepine resistant Enterobacteriaceae is another one. Again, this is a broad bacteria that has a family of over 70 bacteria. They are extremely resistant and associated with high mortality, especially in the bloodstream infection. The mortality can go as high as 50%. When we say carbamazepine resistant Enterobacteriaceae, the definition is that we're talking about those class of antibiotics, imipenem, meropenem, or doripenem. Clostridium is another common organism, which is a commensal of the intestine. And this bacteria has also been important in AMR. The risk is higher where there is a use of broad spectrum antibiotics or people who have serious underlying illnesses and the elderly. This bacteria has spores or forms a spore that can help it to remain in the hospital environment for longer periods. And these are some of the issues sometimes hospitals have to deal with, where you might see a closure of wards and decontamination before we are able to use the facilities again. Methicillin-resistant Staph aureus is a notorious condition, bacteria, where we see usually it might start as a skin infection, but can quickly spread and may go into bloodstream sepsis and may lead to mortality. Superbugs, also known as escape due to the acronym that is used for the 6 bacteria that are listed on the slide. They are usually resistant to multiple drugs and also cause serious infections, whether in post-operative or other kind of infections that we handle every day. So the issue has been gaining prominence, and also we are seeing how devastating the effect of AMR can be. There has been projections as to what can happen if the situation goes unchecked. In this slide, you see that superbugs bigger risk than cancer. If you look at the bottom of the graph, we can see what is the mortality from different causes. But by 2050, AMR is going to be the leading cause of death, contributing to 10 million deaths. Right now, we are around 700,000 deaths per year. Another important observation is also, as already noted in my initial slide, the current studies that did show the problem being more concentrated or higher burden recognized in the African and Asian setup is also likely to go higher if it is unchecked, where we see about more than 4 million deaths by 2050, according to this prediction. Looking at what the global and regional responses have been, and we've been hearing from the presentations, some of the studies and the wonderful work that has been done by some of our colleagues in the region, I'll just highlight the Global Action Plan, which provided a framework for action with some strategic objective, 5 strategic objectives, mainly to improve awareness of AMR. The awareness should go beyond the sectors, whether it is human health, animal health, or environment. It should also involve the public. The second strategy is strengthening the knowledge and evidence base through research and development, reducing infection through infection control mechanisms and processes, limiting the emergence of spread of AMR, and developing new tools to fight AMR. And of course, the surveillance system has been the one which has been gaining more traction and work that has been documented. There has been different standards and guidelines that have been developed, and these also transcend between the 3 sectors: the environment, the animal health, and the human health. Global Antimicrobial Resistance Surveillance System, or GLASS, is a platform for global data sharing. It supports global surveillance and research, and countries should be encouraged and are encouraged to join some of the multi-center studies and platforms to enhance this reporting and using the standardized approach to the collection, analysis, and sharing of data at global level. WHO also has a list of priority antibiotic-resistant bacteria that are monitored. This has 3 tiers: critical, high, and medium priority, and different antibiotics are listed in these groups. And this list or the tier might change for the bacteria based on the research findings. But at least what we can see is having this data is helpful in terms of gauging where our health facilities are, where we are moving towards in terms of determining the resistance pattern, and compare it to the global database in terms of measuring where we're going from the baselines. The strategic research agendas are mainly in the 6 areas. These are therapeutics, diagnostics, surveillance, transmission, environment, and interventions. So again, this kind of gives us a framework where to study which kinds of strategic agenda we would like to focus on based on the gaps that needed to be filled. One of the most important gaps is also the diagnostics that we see, particularly in our region. Mapping of antimicrobial resistance and antimicrobial use partnership project is a consortium of African Society of Laboratory Medicine and others. This project aims to collect from existing data baseline information to map antimicrobial use and also bridge the gap in data through digitalization and identifying areas of improvement for the countries to collect quality data. Policies and strategies, there have been very important policy directions that came out from studies and observation of the direction of AMR. Monitoring the antimicrobial use has been very useful, especially in the formulation of the policy to ban use of antimicrobials for animals for growth promotion. As you know, there are the animal production industry for food is using antibiotics just for growth promotion or getting higher yield in their product. And animals are provided with antibiotics even when they are not sick. So this process has been very critical, and Europe has succeeded in banning the use of antimicrobials in animals for food. And I think that's a great step towards the right direction. Whereas in the US, we have not yet seen this ban, and other countries are also need to see if they can pick up the effort on that regard. It's important to engage the environmental sector as well. Delaying emergence of antimicrobial resistant organisms through antimicrobial stewardship is another important aspect. This is usually done at the hospital level, but needs a policy support and commitment at the highest level to make sure that the organized governance and committees and the resources are available for antimicrobial use and also quality improvement, as well as discussion to show the data sharing across different hospitals to come up with a better plan and decision in moving forward. Limiting the transmission of AMR through infection prevention control, water sanitation and improving hygiene, as well as provision of personal protective equipment is also very critical. These are some of the shortages and the challenges, particularly in our African setting, where we don't have adequate water and sanitation even in hospital facilities, making it difficult to control infection. Strengthening biosecurity programs on farms is also part of the limiting AMR transmission strategies. Mitigating harm among AMR infected patients. This is also an important strategy. This calls for increasing development of new drugs and quality diagnostics to make sure that we are able to handle those cases that are resistant. The main competencies for AMR, especially for those working in the clinical setup and really working in the public health setup to ensure the control efforts is enhanced, are three. The foundations to build awareness, the appropriate use of antimicrobial agents, and infection control practices. The challenges are many, but I'll just highlight a few and then probably focus more on the African continent and talk about the drug discoveries in the next slide. In our setup, high level of AMR is already witnessed and we know about it. More than 1/3 of the countries have no recent AMR data published in the public domain. So the data gap is concerning because without data, influencing policy becomes difficult and implementing corrective measures and strategies that are useful to curb antimicrobial resistance becomes difficult. Another gap is also standardization and quality microbiological identification and susceptibility testing is also lagging. Studies in food animals also suggest that there is a serious threat for food safety and security. This is also a very critical gap, as well as the gap that we see in regulations, counterfeit drugs, being able to purchase antibiotics in formal settings, and also contamination of our waters and supplies because of lack of regulation on industries, where we have some pharma's waste being spilled into drinking water or the water system of the public. These are some of the issues that we can highlight as a challenge for antimicrobial resistance control. Another important global challenge is that if we go back in history, when the penicillin was developed in the 1940s, immediately after that, like between the decade after that, between 1950 to 1960, the discovery of antibiotics were much faster. There were newer drugs and more potent drugs coming to the market rather frequently than what we see after 1960, where we call it a gap or an innovation gap. So there is not a lot of new drugs that will help us move towards more potent drugs to deal with the resistance that we are having. That is a concern and a challenge for us, an area of research, but also an area of concern to ensure that we should try and also make our efforts much more concentrated on keeping the antibiotics that we are using working. That means limiting the resistance pace and making sure that we are using our antibiotics sparingly. Just before I finish, I would like to share the warning that was given by Sir Alexander Fleming, who was the person who discovered penicillin. As we said, resistance occurs naturally, and it was not long after penicillin was discovered that resistance pattern began to emerge. And the warning we had from him was that the time may come when penicillin can be bought by anyone in the shops. Then there is a danger that the ignorant man may easily underdose himself, and by exposing his microbes to non-lethal quantities of the drug makes them resistant. So we did have this warning a long time ago at the beginning of the discovery of antimicrobials, which have changed the picture of infectious diseases, and which was a great milestone in the treatment of infectious diseases. But despite these warnings, we are still having antimicrobial resistance in our setup. So the key messages are that misuse of antibiotics is the main driver of AMR, and we need to counteract this. AMR threatens the effective prevention and treatment of infectious diseases. If we are going the same direction, common infections and minor injuries can become difficult to treat, and we will see higher morbidity and mortality from these causes. Successful surgery becomes difficult, and also cancer chemotherapy and other interventions like transplant may also be compromised. In addition, the cost of healthcare is going to be high, because we will have increased number of days for people to stay in the hospital, as well as treating resistant organism by the second or the third generation of antibiotics will be more expensive. The general precautionary measures that we should aim at also includes enhancing infection prevention control, especially improving our water and sewage systems and managements, and reduce animal use of antibiotics and use of household and personal products that are containing antimicrobials. Policy becomes of paramount importance, especially in the area of optimizing surveillance diagnostics, and the same approach of antimicrobial use. The danger is that in the absence of new drugs in the pipeline, there is a real danger that we may be going back to pre-antibiotic era. And this is a critical issue. But I would like to finish with a positive note that resistance genes are available, or resistance is a reality, but their spread can be delayed. And I think that's where awareness and research is very critical in antimicrobial resistance control.
Thank you, Dr. Senlight, for highlighting this very important and often underestimated issue. And it's really great to see all the work that you're doing to address this. At the moment, I don't see any questions in the chat, so please do add your questions there for Senlight, or you can add your name and we'll call upon you. I'll just ask you one question from myself, if that's okay. You've highlighted about the very high rates of AMR demonstrated in Africa, and also that AMR is a leading cause of death. Before the break, we heard about the use of ICU registries, and I wonder if you see a role for incorporating data collection on antibiotic use within registries like this? And if so, how do you feel it would contribute to tackling AMR or feed into the global surveillance systems and data sharing platforms that you've talked about?
I think that's a very good question. And it's very important, and because the health facility, one, is the main area where we are having antimicrobial resistance, whether the spread or the difficulty to see, and the mortality and the morbidity that we see really gives it a picture of what can happen with antimicrobial resistance. And ICU and acute care settings are also very critical. And it is possible to incorporate this data, even though there is not such a platform that is really laid out. But it is a very interesting idea to start with, and to try and see how this can be incorporated into the picture, where we can kind of see hand in hand what the surveillance shows and what the acute care settings and ICUs contribute, and how many of these resistant organisms end up in ICUs, and what the contribution is. And I think ICU is a perfect place to monitor for AMR. It becomes very critical.
Thank you very much. I don't see any more questions, so we'll move on to our next topic. We'll be talking about indications and challenges for implementing perioperative registries and the characteristics associated with successful registries in low resource settings. And for this, we have two speakers. First, we'll be hearing from Mr. Fitsum Kifley, who is a Global Surgery Fellow at University of Cape Town, South Africa. Fitsum has collaborated on research projects with N4PCC and AppOrg, and he's working towards improving the perioperative surveillance system for quality improvement and research collaborations. He will be joined later by Professor Bruce Picard, who I believe by now needs no further introduction, having contributed substantially to this conference so far, and whom you've heard from this morning. I'll hand over now. Thank you.
Thank you very much, Jolene. Greetings all. This is Fitsum, and I will speak to you about a recent systematic review. So our study aimed to understand the indications and challenges for implementing perioperative registry and characteristics associated with successful registries in low resource settings. So we will go over these presentation outlines in detail. So perioperative registries are databases that store information on surgery, obstetrics, and anesthesia, and later on this information can be utilized for various purposes, like evaluating patient outcomes and developing artificial intelligence predictions, mortality, morbidity predictions, and supporting policymakers and health professionals in making evidence-based decisions and interventions. So the problem is in low middle income countries or on low resource settings, they are in high demand. So our objective, our review objective aims to assess the indication, challenges, and characteristics of successful preoperative registries in these low resource settings. So, the result from this study is expected to benefit, to better understand and support ongoing initiatives to establish preoperative and other clinical registries in Africa and other low middle income countries. So our method was we conducted a librarian-assisted literature search on international research databases, which includes PubMed, Cochrane, Web of Science, and Scopus. This search was conducted from 22nd of June to August 10, 2021, and our search was limited to English studies, and we used mixed method appraisal tool for screening. So in terms of our inclusion criteria, we used PICO, PICO model, so population intervention and outcomes, and hence that made all of the following criteria were included. In terms of setting, countries with large preoperative registry or network, and hospitals in low or middle income countries. And the outcome of interest was implementation of preoperative registry in low resource settings, and the outcomes were indication, challenges, and characteristics associated with successful registries in low or middle income countries. So we tried to include quantitative, qualitative, and or mixed method studies. Then we excluded studies that were not part of primary research, such as articles reported to conference, commentaries, editorials, systematic review, meta-analysis, and other secondary studies were excluded, and studies that were not in English were also excluded, and when we were not able to find the full text, we excluded these type of studies. And on the MMT tool, or mixed method appraisal tool, there are two screening questions, and if the answer was no for either or both questions, so we excluded that study. So the questions were, the screening questions were, do the collected data information allow to address the research questions? And the next one is, are there clear research questions on the study? So if no for any of these questions, for any of these questions, then the literature will be screened. But if the answer were can't tell for both of the questions, then the research, the article will go for full text review. And in order to avoid inclusion bias, the studies were screened by two researchers, and so where there were disagreements, the third researcher resolved them. So when we see our results, a total of 2,793 literature were screened, and 900 duplicate records were removed, and 1,840 recruiters were excluded based on the responses to the screening questions of the appraisal tool, and that is no for either or both questions. Those studies who were cancelled for both screening questions against the titles and abstracts were further screened for full review, and here 9 were excluded, as 4 were no for both questions and 5 were no for the first the mixed meta appraisal tool. The 13 full articles with 2 yes answers for the MMT screening were reviewed, and 3 were excluded since only the English abstracts were available. The full articles were not in English. So finally, then we included 10 eligible studies. When we see the indications for preoperative registries in LMICs, in this review of 10 articles, the biggest reason for implementing preoperative registries was to know patients' outcome. This message is quite important since it clearly outlined the challenges of knowing surgical patients' outcomes in developing countries. So investigators will be forced to try to build these registries from the scratch, and again from that study, again they will from that intervention, then again they will try to evaluate patients' outcomes. One thing that should be mentioned here, so in this review, most of the registries arose from investigators with specific outcome interests, which remains helpful in determining and minimizing the data sets. So this is quite important. The other reasons for implementing preoperative registries is conducting quality improvement initiatives and research, and also identifying risk factors, and also informing policy and practice. Then in one place, the identifying in a couple of places, identifying short-term and long-term training needs for medical and other health professionals is also mentioned. So when we see the challenges, so the main challenge was incomplete data, and of course there are the other mentioned reasons here can contribute for this. For example, the lack of finances, the level of training for data collectors, and the lack of technical team on the ground can play a role for data incompleteness. The other challenge is trust issue on data collection and software and storage. So in 3 of the articles, this was mentioned, and the other is high costs for software support from outside the country due to lack of an established technical team within the host country. So if there is a well-established system or technical team on the ground, especially within the hosting country, so it will be quite easy. So because the remaining task will be coordinating this team and trying to do the work. So, but in the absence of well-established team on the ground, this is quite difficult. Then lack of policy for data management and sharing. Yeah, even though this is mentioned or cited in 3 studies, it plays significant role in making the process more difficult in low middle income countries. Since it causes investigators to knock numerous doors seeking support for collaboration, and this takes several time and also depend on the collaborators' personal interest and willingness. The other is insufficient funds to organize team, recruit data collectors. Is also mentioned. So when we see the characteristics, so engaging different stakeholders is quite important because there is no clear guidelines for data management and sharing. So engaging different stakeholders, obtaining appropriate ethical approvals, building local research capacity, and also providing adequate training for data collectors before commencing data collection. Then appropriate recruitment of data collectors in terms of skill mix and academic background ability are associated with successful registries. When we see the software or mobile applications, the design software and programs needs to be offline compatible and need to require a low bandwidth. This will help to avoid local constraints such as unreliable connectivity and also insufficient power supplies. And so again, the software needs to be easily adaptable and also locally made. So regarding the platforms or the storage, it should be very transparent and it should use secure platform and needs to allow decentralization and fair principles of data management, i.e. Findable, accessible, interoperable, and reusable. Then in one place, automated analysis and public view of core surgical indicators were also associated with successful registries. So in conclusion, the goal of preparatory registry is to generate data to influence and support national surgical policies and improve patients' outcomes. To address the enormous need for surgical treatments, improve the quality of care care offered, and prevent falling behind in the field of continuous data-related technological advancements, every effort should be made to build these minimal dataset registries, particularly in sub-Saharan Africa. So, having reviewed all this and understanding the pressing need for preoperative registries in Africa, Upper Network is seeking to establish a Pan-African preoperative registry network that encompasses all the characteristics associated with successful registries in low resource settings. So we hope your hospital or country or institution will contribute and collaborate to this plan and make it a success. Great, thank you very much.
Thank you, Fitsum. I believe we're going to go straight over to Professor Bruce Picard.
Thank you, Jolene, and thank you, Fitsum. So I think Fitsum has laid the ground for what one needs to do to have successful perioperative registries or registries in low resource environments. And I'm just going, this is an extremely short talk on the African perioperative registry and participation in it. So the registry will be supported by the African Perioperative Network and by Safe Surgery South Africa. And as I've said before, some of the funding for the Perioperative Network has been kindly provided by EPBOM. So these are things I just want to touch on quickly. Why a registry? What would the registry be? How would we do it? And what are the benefits? So why an African perioperative registry? We know that perioperative outcomes and resources are limited in our environment. If we have locally owned data, we can use it for advocacy in our own environment. And we can also use it to track quality improvement initiatives. And at a continental level, if we have similar data, we can use it for leverage and advocacy internationally. So our first registry we propose is for perioperative mortality rate. We've conducted the Delphi and we've established the limited variables which would be required for minimum data set in Africa. And this would allow us to provide risk-adjusted mortality figures for institutions, and it would allow us to track our performance at our local sites. It's really important, perioperative mortality rate, as it is one of the Lancet Commission's for Global Surgeries indicators. From the minimum data set, one would need a limited number of variables in order to be able to do this and to risk adjust for mortality. And so essentially, these are the variables for the perioperative mortality rate data set. They're 10 variables, and it would be risk adjusted using ASOS surgical risk calculator. And we know from ASOS 2, where we use the risk calculator, that it performed very well in identifying our high-risk patient. So we're in the stage of the pilot phase participation, which is establishing a core set of hospitals, countries who want to participate. We're looking at sites to contribute either to defined set of surgical procedures or surgical disciplines, and then the sites to have local co-development in participation in the registry. And you can register your interest for participation on the African Perioperative Network database, and that's a QR code. The benefits of participating: well, you would have your own locally owned data, and it would also be risk adjusted. You can track your quality improvement initiatives at your own site, and you can use it for advocacy at your own site as well. So if you want to participate, please register your interest over here. So in summary, why do we need a registry? Well, the outcomes in Africa and the resources we have are limited, and outcomes are poor. We know that perioperative mortality rate is one of the Lancet Commission indicators, and we should all strive to provide that data. You can participate at this point in the pilot phase participation or setting up the data registry. And the benefits is that it gives you locally owned risk-adjusted data, which you can use for your own quality improvement projects. Thank you.
Thank you both for that excellent overview of the current situation regarding perioperative registries in Africa. And it's very exciting to hear about the plans for the APORN registry. I'm not sure if Fitsum is back with us. He was having some connection issues, I think, but he's trying his best to get back online. I don't see any questions in the chat at the moment. So as before, if you've anything to ask, please do drop it in there or drop your name in there. One thing that I was going to ask about, and Bruce, I don't know if this would be the best question for yourself or for Fitsum. So if he's not back, we can always put it in the chat for him. He talked quite a bit about data storage issues and concerns and the importance of addressing that. And I wonder if you'd had some thoughts about how you might try to address some of those issues within development of the APORN registry.
So the experts in this space are Fitsum and Hela. I'm not sure if Hela's on the call.
I am here, Bruce.
You are. Hela, sorry to put you on the spot. I mean, would you be able to respond to Jolene's question?
Yeah, Jolene, I think you know, Luigi illustrated in his talk earlier on the critical care registry. He showed the architecture there of, it's almost like a combined architecture and data governance model. And I think if you don't have a plan up front with regards to your data management plan and your data sharing plan, you know, then you're bound to run into trouble. And that's one thing that we're definitely focusing on is to have a pre-developed data governance and data sharing plan that that aligns with the FAIR principles, but has got very specific users and use case scenarios, both at a local or even a team level, as well as on a regional and national level, and then continental level. So, so we will be addressing those plans. You know, it depends very much on what is locally the culture, and you know, and I'm not talking just about a facility. I'm more talking about a national incentive. And personally, you know, I feel that the stakeholder and community engagement part of the projects is crucial to success. And while we accept that these initiatives must be clinician driven, it has to be supported by government. It has to be supported, and not necessarily financially. I don't think there's a lot of African countries that that's able to support financially such initiatives by clinicians. But I think what is important is that conversations need to happen. Conversations with policymakers before, you know, to make them buy into the concept at the same time that you're developing your sharing plan and everything else. Because that support just makes it so much easier to ensure that there is regulatory approval for the system, that there is ethics approval, but it also speaks to the sustainability of the model. So, you know, stakeholder, and I think it's one of Fitsum's slides there, where he speaks about stakeholder engagement, which I think is scored there in his slide as the highest in the requirements for setting up such a registry. And I believe that, and I know that people that are already interested in participating in this pilot have got those, engagements going, and that will influence, obviously to a large degree what your data management plan is going to look like as well. I hope that answers your question, Jolene. I'm not exactly sure.
Thank you very much, Hyla, for stepping in. That was very helpful. I'm not sure if Fitzim is back with us. I think I'll just check if he's here. Fitzim, are you back with us? Not yet. So we'll just move on to our final speaker, who's Dr. Tajuddin Raji, who's Head of Public Health Institute and Research at CDC Africa. Specialised in paediatrics and public health, and with many years' experience in maternal and child health, humanitarian emergencies, health system strengthening, and workforce development, Dr. Tajuddin will be speaking to us about this Africa CDC's experience and recommendations for the regional acute clinical care research community on building evidence, identifying gaps, and developing standard collaborative regional interventions. I'll hand over to you.
Thank you, Jolene, for that introduction. Let me try to share my screen. I have a couple of slides to take us through my presentation this morning. All right, can you see my screen?
Yes, we can, thank you.
Okay, all right. No, so once again, thank you, Jolene. So I bring you greetings from the African Union Commission. I also bring you greetings from John Nkegasong, the director of Africa CDC, who have actually loved to be here this morning, to actually do this presentation himself, but unfortunately he's far away in Washington. And let me also, use my Cape Town, affiliation to greet a colleague from UCT. So a couple of years back, I was at UWC for my public health postgraduate training. So having said that, I will attempt to take you through the Africa CDC's experience and recommendation for acute clinical care research community on building evidence, identifying gaps, and developing standards using sort of a regional approach. And as you can see there, my name is Tajuddin Raji. I work for the Africa CDC. So, by way of introduction, the Africa CDC is a specialized technical agency of the African Union. And as we all know, the African Union is an intergovernmental organization. Africa CDC came into existence exactly 5 years ago when it was launched by our head of state government under the leadership of the then chairperson of African Union Commission, Madam Nkosazana Dlamini Zuma. And as part of our operating model of the Africa CDC, we have the headquarters at Addis Ababa within the African Union Commission. In each of the 5 African Union regions, we have what we call the regional collaborating centers. And at the level of each and every member state, we have what we call the National Public Health Institute, just like what you have in Ethiopia called the Ethiopia Public Health Institute, and what you have in South Africa called the National Institute for Communicable Diseases. It's also like the US CDC equivalent in Atlanta. Now, if you take a look at our strategic plan, looking at the strategic pillars, there are 5 main strategic pillars for the Africa CDC, and we have some couple of cross-cutting enablers for those pillars. Now, of keynote there is that pillar that is looking at National Public Health Institute and research. So this is basically health system strengthening, research, and then some element of our workforce development. But much more importantly, if you look at all the other 4 pillars, you discover that research is a core component of that. If you look at surveillance, emergency preparedness and response, if you look at lab systems and networks, and of course, information system. And Julian, just to close up the previous session, you asked a question on data, and that pillar there, information system, is exactly what Africa CDC is trying to do at the continent level to bring all our member states to speed in terms of capacity and ability to share data and use data to inform policy and practice. Now, having said that, let me shift there and go to COVID-19 pandemic and the response and what have we done as Africa CDC. So just a week into the COVID-19 pandemic, we convey a high-level emergency ministerial meeting that brought together all the 55 member state ministers of health. And at that particular meeting, we did agree on the need to have a continental strategy to drive our response, the need to coordinate, collaborate, communicate, and cooperate as a way to effectively marshal a very good response as a continent using regional approach. And that regional approach, I think, underpins or is a critical aspect of what we are discussing here today. And let me also state here that if there's anything we've seen as far as this COVID-19 pandemic is concerned, is we have actually realized that clinical care, is much, much more closer to public care than what we usually think of. Because when you look at the COVID-19 pandemic, the proportion of patients who get admitted and those who go into the, the critical care unit, to optimize their care. So the COVID-19 pandemic has underscored a very strong tie between clinical care and public health. Now, as part of the continental strategy, we were mandated by the Ministers of Health to put in place different technical working groups. Now, for the sake of this discussion, part of this technical working included technical working group on case management. Coincidentally, that is also co-chaired by Africa CDC and South Africa. And another technical working group that is looking at research standard and regulation, that brought together most of the researchers on the continent on how do we, use evidence, that is coming in to guide our response to the COVID-19 pandemic as a continent. It's sort of locally contextualized evidence to guide our response on the continent of Africa. Another key lesson that we learn as far as the COVID-19 pandemic is concerned is the critical role of our National Public Health Institute, by extension, our local research institutions, our academia, and so on and so forth, because we believe that, what the COVID-19 actually told us or actually showed us is the fact that all these key institutions need to collaborate, need to coordinate to be able to mount an effective and efficient response to the pandemic on the continent. Again, we also learned that there is need to have a locally contextualized guideline to drive the response. And you will agree with me that you cannot talk of a locally contextualized guideline for a continent of 1.3 billion people, 55 member states, without looking at it from a regional point of view, without regional coordination and collaboration, which again underpin what you are doing here today. And we have several guidelines on infection prevention and control, case management, critical care, and so on and so forth. And all these were work done through that regional collaborative approach, through the researchers, the lead experts, critical care, case managers, surveillance experts, and so on and so forth on the continent. And all these guidelines were actually used to support our member state response to the COVID-19 pandemic. One other key lesson, as far as this COVID-19 pandemic response is concerned, is that critical importance of political leadership. Without that political leadership, there is no way we could have achieved most of what we achieved, notably that of equitable and affordable access to what I describe as security commodities, things like oxygen, things like personal protective equipment, therapeutics, vaccines, diagnosis. Without the support of our head of state and government, there's no way we could have achieved that. And as you can see on the screen then, at that time, our chair, when the COVID-19 started in 2020 was Cyril Ramaphosa. And shortly after that, President Felix Sekedi of DR Congo took over. And of course, our own chairperson at the commission, Faki Mamat. All these were instrumental to the successful response of Africa CDC to the COVID-19 pandemic on the continent. Another key lesson is the importance of diagnostic. But much more importantly, the need to build local capacity. When COVID-19 struck, there were only 2 labs or 2 countries on the entire continent that could do or that could test for the SARS-CoV-2. These 2 countries were Senegal and South Africa. Fast forward, with the support of those 2 countries, with the support of our researchers on the continent, and with some international support, we were able to scale up, to the entire continent before the end of that 2020, through a series of training at Institute Pasteur in Dakar and NICD in South Africa. Another key lesson is the importance to build our local manufacturing capacity for vaccines. Today, colleagues, ladies and gentlemen, of all the vaccines that are consumed on the continent of Africa, only 1% is produced locally. 99% is imported. There is no way you can guarantee our security this way. So critically, we need to begin to have that robust discussion on building local manufacturing capacity for vaccine on the continent. And there cannot be local manufacturing capacity without research and development, which further key into what we are discussing here today. Workforce development was also another key lesson. You cannot talk of research, be it acute care, be it clinical care, be it core public health issues without adequate workforce. In fact, one of the challenges, one of the critical gaps as far as health research on the continent is concerned is that lack of capacity. And what we have seen from our mapping is that that gap is quite huge. For instance, if you look at field epidemiologists at advanced and intermediate level, as a continent, what we need is roughly 6,000. What we have today is just 1,900. So look at the gap there. And this cut across the entire continent. Look at our frontline epidemiologists. These are people who are supposed to be at the community level. These are the people who call like surveillance assistants. These are the first point of contact whenever there is any emerging or re-emerging infectious disease. Today, what we currently have is 5,000. What we need is 25,000. So the gap is there for all of us to see. When you go to community health workers, the same thing. When you go to critical care capacity, it's even worse off. We did a mapping exercise at the onset of this pandemic. Apologies, I couldn't pull that slide before this particular conference. The gap is appalling. In fact, I used to use one particular phrase when I'm talking to our political leaders, that some of our member states actually have more vice presidents, than critical care experts in their country. Should it be that way? No. So again, which underscored the importance of what we are doing here today. I also underscored the importance of capacity for research. So the COVID-19 pandemic also underscored the importance of critical care equipment, especially medical grade oxygen. And I'm sure all of us have seen the appalling data, coming out of the mapping, into what exactly do we have on the continent as far as these critical care resources are concerned. So again, Africa CDC is more than glad to be part of this, and we'll be more than glad to see what are the things that we need to do going forward to make sure that we build the necessary capacity as far as acute care on the continent is concerned. So let me shift there and try to focus a bit more on why we are here today. You all agree with me that just a few weeks after the COVID-19 pandemic, after the SARS-CoV-2, was discovered as a causative organism for the COVID-19, the genomic sequencing was released. And since that particular time, Africa CDC has continued to work with all the different research institutions on the continent to make sure that we put in place a very robust molecular surveillance capacity on the continent. And currently we're supporting 12 centers of excellence in Africa, including Capri, yes, that's in Durban, another center in Cape Town, and of course NICD. We continue to work with institutions like Ethiopia Public Health Institute, Cambridge in Kenya, Nairobi, the Nigeria Centers for Disease Control, the Institute Pasteur in Morocco, and so on and so forth. And for those members without this capacity, we also continue to provide some sort of remote assistance to them and facilitate the transport of their specimens to all these 12 centers of excellence. And we continue to organize different capacity building exercises so as to ensure that each and every member state is carried along as far as this molecular surveillance of different variants is concerned. So with this, we have been able to continuously monitor the SARS-CoV-2 mutations, which has huge implications on clinical care and by extension, huge implication on research. In fact, without that research, I don't know we can pick some of these variants of concern. And of course, we continue to use findings from our molecular surveillance to investigate and inform our outbreak and response, to monitor how our diagnostics are doing, therapeutics, and much more importantly, vaccine efficacy. Again, we know that with the sequencing capacity that we are building on the continent, we have been able to use some of these to guide the development of treatment, vaccines, diagnostics, and other security commodities. Notably, the variant or the genomic sequencing results or findings have been used to develop monoclonal antibodies, some antivirals, and some of our diagnostic kits, not only in the global north, including on our continent. One is impressed by the good work that has been done in Morocco, where they've developed rapid diagnosis tech for COVID-19, so also PCR test kits with very rapid turnaround time. And for Africa CDC, we continue to support all these indigenous institutions to make sure that their capacity continue to grow from strength to strength. Again, vaccines have been a critical component of the response to this COVID-19 vaccine, the COVID-19 pandemic. And you will agree with me that there can be no vaccine without research and development. And while the continent continues to struggle, to move from 10% to 70%, surely, there will be a lot of cases coming to our healthcare facilities. And for as long as we continue to see more cases at our healthcare facilities, we continue to see a lot of cases within the acute care setup. And for as long as we continue to see cases within the acute care setup, we need to continue to come up with evidence, to better guide our management of such cases, And we also continue to support member states to build their COVID-19 vaccine technologies, such as the mRNA. And one is also quite impressed with a lot of advances that have been made within the couple of years, thanks to research, to accelerate what has actually dragged on for close to 25 years, and our ability to have been able to accelerate that in the space of 15 months. And on the continent, we continue to support the different clinical trial research sites, with many grants, with technical assistance, so that they are part and parcel of the COVID-19 vaccine development exercise. But much more importantly, to be able to sustain that beyond COVID-19 pandemic and use what we have gained now, the opportunities, the capacity that we have built now, to shift that needle from 1% of vaccine being produced on the continent of Africa to that of 60% come year 2040. So these are some of the achievements we've made as far as the vaccine landscape is concerned. And this is also thanks to a lot of research and development that's gone into this, from Senegal to Morocco to South Africa to Egypt to Algeria. And we continue to support other member states. Partners also continue to provide a lot of support as far as research and development on the continent is concerned. We have the MasterCard Foundation, who out of their generosity have provided huge amount of money, groundbreaking, unprecedented, first time in history, 1.5 billion to support Africa CDC effort, on the continent. And a key component of what this fund will go into is to build research capacity on the continent, to support our institution, to build their capacity, and much more importantly, to also begin to regionalize our approach. We have all seen what the global mechanism can do, when they are challenged. Needless to say, to mention the fact that we are seeing colonization or recolonization of global health, including research. So what do we see as future of research? Health research, to be more specific, on the continent of Africa. We want to see a locally driven agenda or priority setting of health research. What do we mean by that? That whatever agenda or priority should, as much as possible, be locally contextualized. We want to see strengthening of capacity of our regional institutions, especially the academic institutions. We also want to see meaningful engagement of researchers, from low and middle income countries in all health-related studies and publications. So in terms of rethinking global health research agenda, we want to see involvement of our experts when it comes to setting agenda, when it comes to priority setting. Let's avoid a situation whereby what we see is a trickle-down effect, or what we see is something that has been determined as well, and we are just only implementers. Let's empower our colleagues locally to have the necessary capacity to be part of that agenda and priority setting. Let's also ensure that research is adequately financed. The science, technology, and innovation strategy for Africa, has informed our member states that at least 1% of the GDP should go into research. So let's see actualization, let's see implementation of that declaration by our head of state and government, to make sure that 1% of our GDP actually go into health research agenda. We also want to see focus on strengthening health systems, especially in low and middle income countries, because this is the only way we can sustain all the different programs, projects, initiatives, and so on and so forth on the continent. Let's get them institutionalized. One Health is also key, especially given the fact that more than 70% of our emerging and re-emerging infectious diseases are actually of animal origin. It's only through One Health that we can begin to have a comprehensive approach to things like surveillance and diagnostics, health diplomacy, communication, behavioral science, research ethics, emerging technologies, and research and development in general. The second approach from Africa CDC, or opportunity that we see, is to strengthen capacity of our institutions. And as Africa CDC, we continue to work with all these institutions. In fact, when you look at our operating model again, our engagement at the level of our member state are through the different public health institutions, including academia. So, colleagues, ladies and gentlemen, capacity building and training of local staff is key if you are to make any meaningful progress. 2, respected partnership and collaboration to advance knowledge and technology transfer is also very important. Funding, again, for point of emphasis, is key if you have to make any meaningful progress. So in terms of engagement, in health research agenda, we continue to build the capacity of our member states to ensure that whatever public health research agenda that is out there, we continue to lead from the front, especially when it has to do with research in low and middle income countries. Is our right to take the lead. And again, when we get all those studies carried out, we also want to ensure that we have a means of sharing our stories. We have a means of popularizing whatever or publicizing whatever we have been able to generate. Our data should be out there for people to see, and we'll continue to work with the different, peer review journals to ensure that our voices are heard. So these are some of what we published during the course of this COVID-19 pandemic. The aspect of COVID-19 vaccine, how to ensure Africa has access. These are myself, colleagues. The same thing on the issue of documenting what the first and second wave of COVID-19 pandemic in Africa has been like. So again, these are colleagues from Africa CDC and a colleague from different national public health institute. So, final takeaway, colleague. The COVID-19 pandemic has presented some challenges, especially in the aspect of research. The pandemic has affected data collection on the field. It has also shifted our focus from other diseases to COVID-19, despite repeated calls from Africa CDC and other international partners. Our study participants are not forthcoming for fear of contracting COVID-19. Research funding has been diverted to support other COVID-19 response. Some research sites have been repurposed for COVID-19 care. A good example is in Ethiopia, where one of the TB sites has been repurposed for COVID-19 treatment. The story is the same in other member states. We have also seen fragmentation of research approach, and going forward, we also know that the pandemic has presented a lot of opportunities. So as much as possible, let's capitalize on some of those opportunities. We know that the pandemic has led to renewed interest in public health and clinical research. For instance, let me give you an example. Before now, I'm not sure there's been any avenue for Africa CDC, to have direct engagement with our head of state and government. Today, we have had the privilege of talking to the African head of state and government 17 different times, to discuss this COVID-19 pandemic, to discuss how do we be back better and stronger, to discuss how do we begin to generate evidence to inform our own response locally. So colleagues, ladies and gentlemen, interest is there. So if you not capitalize on the interest now, if we do not make use of the opportunity that has been presented by this COVID-19 pandemic, then I don't know when we're going to get the listening ears, of our political leadership. The pandemic has also led to improvement in research collaboration. We have seen collaboration getting strengthened between Africa CDC, our WHO, Africa Academy of Sciences. We have seen a lot of interest. We've seen a collaboration between Africa CDC, Addis Ababa University of Stellenbosch, with in Joburg, École Nationale Santé Publique in Rabat, Morocco. So the pandemic has provided a lot of improvement in research collaboration. So we need to sustain that. We need to make use of the momentum that has been brought about by this COVID-19 pandemic. And of course, we have seen a lot of improvement in research and ethics, and Africa CDC continue to support capacity, and we continue to emphasize on the importance of regionalizing our approach, which further underscore what we are doing here today. So colleagues, ladies and gentlemen, before I round up, Africa CDC continue to advocate for a new public health order. This new public health order talks of the importance of strengthening our public health institutions, including academia. This new public health order continues to emphasize on the need for adaptive public health workforce. We need to continue to build our research capacity. We need to continue to build capacity for critical care, capacity for surveillance, and so on and so forth. We need to continue to build our local manufacturing capacity for vaccines, diagnostics, personal protective equipment, therapeutics, and other equally important health security commodities. And we continue to advocate for action-oriented, respective partnership. That also key into what we are doing here today, because I can see a consortium of institutions, coming out of what we are doing for the past 2 days. Finally, it is crucial to keep an eye on the potential upsurge of COVID-19. We know there will be waves upon waves of this COVID-19 pandemic, but this should not be at the cost of public health or any health research, including acute care. Pandemics offer the only opportunity to carry out certain research. The pandemic has further underscored the need for more investment and better coordination in public research. And for Africa CDC, we want to see surgery. We want to see global surgery as a core component, as a critical component of our public or of our primary healthcare system, because that is the only way we can guarantee the health security of 1.3 billion people and 55 member states. Thank you. Over to you, Jolene.
Thank you so much, Dr. Tajuddin, for sharing this work with us and everything that CDC Africa is doing around health research. We are running a little tight on time, and I don't see any questions, so I'll just put a call out to see if there are any questions before we move on. Okay, so we're going to move on now to our closing speech. And for this, I'm going to invite Dr. Salome Mswemi, and I hope I pronounced that correct, so if not, please do correct me. Dr. Salome is an associate professor and head of global surgery division at the University of Cape Town. She is World Economic Forum Young Scientist, a member of the Academy of Science South Africa, VP of Women in Global Health South Africa, and president of the South African Clinical Scientists Society, as well as being a board member of the Health Systems Trust South Africa. She specialized in obstetrics and gynecology and has completed postdoctoral research in Massachusetts and in Harvard, and has a certificate in leadership from MIT. She has received numerous awards for her research in maternal health, and we're delighted to have her join us today. So finally, I would like to thank you all for attending this conference, and I want to extend a big thank you to all of our speakers for your time and your contribution, and to our organisers for making this conference happen. We will end with a closing speech. Thank you very much.
Thank you so much. Really delighted to be here. I hope you can see me and hear me.
Yes, we can. Thank you.
Thank you. Firstly, I just put some slides together. I think I had the easiest job to sit and listen to everyone and put together some closing thoughts and remarks. And so I'll share my thoughts. But firstly, just to say huge congratulations to the organizing team first on putting together such an excellent program. I think what I really loved about it was bringing the different stakeholders together from the Ministry of Health, Africa CDC, the clinicians and people from different countries, researchers. And so I think it was a truly international, national and African conference all in one. So well done to the team. And also to congratulate all the speakers, not just on the excellent talks, but on the work that you've done. A lot of you presented a lot of research that you've done with the various networks, and that's really inspiring and encouraging. And what I liked was the consistent African theme around it, and everyone showing how they are collaborating, participating, partnering within the continent. But I thought I'd just touch on a few themes that I thought were important for us to take home and walk away with some recommendations. And so as stated very clearly, we know that this conference was about building African acute care research capacity as a priority in global health. And I think if you break it down, you've got a number of themes that come out of that. It's the research, it's the acute care, it's the global health. But I think most importantly for this conference, research capacity came out the loudest. And I think the important questions that we should walk away with is there research being done? And I think the answer is yes. A lot of research is going on, maybe not enough, but there is a lot of research that is going on. But who is doing the research? Are we simply collaborating, partnering? Are we collecting data? Or are we actually writing these research questions and leading these research themes? Who is asking the research questions? Are these national priorities or are these international priorities? And so important to figure out and to look at whether we are simply responding to what others are bringing in, or whether we are actually writing down and are we the ones writing the research proposals? And who owns the data? Are the research collaborations equitable? Do we have the skills to do the research that we should be doing? Have we created an environment that will support the research that we want to do? Is there a balance between international research and locally driven research? Because it it's so easy to get caught up in research collaborations and not do your own writing. And I think as Africa, we'll only move forward when we start writing our own research proposals. And then is this research reaching the policymakers? And with international research, it isn't always easy to get to the policymakers because it's not necessarily a national priority. It's a priority in the international scheme of things, but only us as locals can come up with national priority research that will interest the policymakers as well. And so important to mention, who is looking after the sickest patients. And so I think that's where the whole part on critical care becomes so important, because it's not the patients just coming into the system, it's what happens to the sickest patients. And we've seen with maternal mortality work that, the patients that die are the ones that could not access the specialists, the critical care specialists. They couldn't get into an ICU. And so we need to relook how we're building the system so that we're not stopping halfway, but the sickest patients will survive as well. So what is the national strategy to increase capacity? Many have emphasized the what and the why we should do what we do in the research, but very few go into the how. And that's how we stay behind, because no one is telling us, not enough people are training us on how to do the actual research, on how to develop research teams, research institutes, etc. And so we stay behind as Africans because we're contributing to what others are doing, but not doing our own how. So it's important to figure that out and work that out. I thought I'll just share a snippet of my own journey from being an obstetrician, a frontline clinician, to being a clinician scientist. And so I realized as a junior doctor that, I was limited. When my patients were sick, I didn't know what to do. I had to refer them, and hence I decided to specialize. But once I specialized, I realized that, okay, now I'm looking after, I can sort out the issues in my hospital, but I can't sort out the population's issues. And that's when I moved into this journey of becoming a researcher, going into my PhD, postdoc, etc. But what I've realized is that as a clinician scientist, you find yourself having both the ear of the clinicians, the frontliners, as well as the policymakers. And I think as countries start to invest in developing clinician scientists, surgical scientists, and anesthetic scientists who will lead their own research and become experts, I think that's where we'll start seeing a big change in Africa. So investment in building African acute care research capacity is a priority. I think global surgery is one important way of doing this, because as global surgery, we not only look at the services that we're delivering, we look at the health systems, we look at the policies. And so I think global surgery is moving us into a new dimension where we can start looking at improving a system on all levels. And I think that's what we should all be starting to invest in. And so my recommendations, which have somewhat disappeared, are that we need to have a clear human resources for health strategy nationally. We shouldn't leave it to chance. We need to know how many specialists do we need? How many critical care intensivists do we need? That needs to be part of the national plan. We need to invest in clinical and research capacity, research infrastructure, and protected research time. It's one thing to say, let's do the research, but if there's no investment time or infrastructure, we're setting people up for failure. And lastly, we need a strategy to develop a pipeline of health African experts, the next generation of academic scientists, professors, to lead research on national priorities and inform policy that will contribute, and people that will contribute to the global health dialogue. So I hope you have all been inspired by this conference, and I hope that as we go along, many of you will be looking at not just doing research, but becoming surgical scientists, influencing policy, influencing care, and ultimately having Africans who are sitting on those tables and feeding into what the world should be doing. So thank you very much to all of you, and I'd really like to wish you all a great day ahead, and kudos to the team. And we look forward to having another conference like this in the future. Thank you so much.